Okay, g'day guys, and welcome to the final part of this series on oxygen, hemoglobin and blood. My name is Dr. Budama Naniakara, respiratory and sleep physician at Orange Health Service, lecturer in medicine at Charles Sturt and clinical lecturer in medicine at University of Sydney. So, as always, we'll just recap the take-home messages that we've learnt. We've learnt that oxygen is fundamental to aerobic respiration to generate ATP. We've learnt the brief anatomy of the cardiorespiratory system and how oxygen goes in from the environment into the lungs, in through to the pulmonary circulation, transported via bulk flow with the pressure head created by the heart, with the blood that's oxygenated going to the tissue from which the mitochondria extract oxygen to produce ATP. We introduced the problem that oxygen by itself is poorly soluble in blood, and soluble oxygen is not very good for carrying oxygen. And we've introduced that we need the transport protein haemoglobin in order to support the requirements for oxygen. We discussed in detail with regards to the structure of hemoglobin and its various physiological adaptations. We then talked about the fact that hemoglobin is carried in red cells, and one thing that I would quickly point out here, which I probably failed to mention in my other section pertaining to red cells, is that if we didn't have red cells, then hemoglobin would be free in solution, and the problem with that is that hemoglobin carries an osmotic or oncotic potential, and that would greatly increase the viscosity of the blood, making it very thick and promoting a lot of fluid retention within the capillaries. So it's important for hemoglobin to be housed within the red cells. And we talked a bit about some of the structural modifications and some of the fragility of the red cell because of this problem. And now we're going to introduce the delivery of oxygen equation, which I think is the most important equation in all of medicine. So I think this is something worthwhile knowing. And we're going to see that the delivery of oxygen really depends on the hemoglobin concentration, the cardiac output, how much blood per litre per minute that the heart can pump out, as well as the amount of oxygen that hemoglobin carries, or the oxygen saturation of hemoglobin. Remember the oxygen dissociation curve. So, we've had a look at this picture before. This is the picture of the lungs, right side of the heart, left side of the heart. So, what do we know? So, the delivery of oxygen must be equal to the oxygen content in the arteries after the oxygen has come in from the environment into the lungs, dissolved via its partial pressure gradient into the pulmonary capillaries. It must be, that's where the oxygen comes from, as well as the blood flow to bring it into the tissues. So it must follow that the delivery of oxygen is equal to the oxygen contained in the blood, which is only in two forms. It's oxygen in hemoglobin, and we figured out the importance of that, as well as the dissolved oxygen in blood. And we remember that the solubility coefficient for oxygen is 0.003 milliliters per liter per millimeter of mercury. Very minimal. As well as the cardiac output in liters per minute. So let's have a look at each of these components. So firstly, how do we compute the oxygen in hemoglobin? Well, remember that a fully saturated molecule of hemoglobin can carry 1.39 mils of oxygen per gram of hemoglobin. So, 90 and if you have oxygen hemoglobin saturations of 90%, that will be 90% of this value. Sorry, let me just erase some of that. Now, what about the dissolved oxygen? Well, the dissolved oxygen is simply the partial pressure of oxygen. Remember, room air, it was 100 millimeters of mercury, times the solubility coefficient. Again, very minimal. And what about the cardiac output? Well, the cardiac output is simply equal to the stroke volume times the heart rate. Now, you'll learn this in far greater detail when we come to our cardiac block, but it all makes sense. The stroke volume is simply the amount of volume of blood pumped by the heart per beat, and the heart rate is simply the beats per minute. So it makes sense then cardiac output would be expressed as stroke volume times heart rate. So if we combine all of these and we put it back into our equation 1, we will have our delivery of oxygen equation. This component here is our cardiac output, stroke volume times heart rate. This component here is the amount of oxygen that is carried in hemoglobin. And this component here is the piddly amount that's dissolved oxygen in blood. Really, we can essentially discount this, because for all intents and purpose, it's minimal. Okay, let's have a look at this component and we'll talk through it. So, what is going to influence the saturation of oxygen in hemoglobin? Remember that the saturation of oxygen is related to the partial pressure of oxygen through this sigmoidal relationship. And as we increase the partial pressure of oxygen, we increase the saturation of oxygen. So what's going to increase the partial pressure of oxygen? Well, simply having more oxygen entrained. So if we breathe in oxygen of higher FiO2, so we add supplemental oxygen, we're going to increase our partial pressure of oxygen. If we increase our ventilation, we're also going to deliver more oxygen into the alveoli, and we're going to improve our partial pressure of oxygen. Now, if we have an impairment in ventilation, we're not going to be bringing oxygen in. The other critical thing with impairments in ventilation is that, remember, ventilation was the only way of getting carbon dioxide out. And if we cannot get carbon dioxide out, then the partial pressure of carbon dioxide goes up. So if we have an impairment of our oxygen saturations, and we also find out that by measurement our carbon dioxide levels have increased, at least a component of the reason why we're having low oxygen levels is because we have a ventilation failure. We're not ventilating our lungs. We're not exchanging gases. Probably the most important thing is VQ matching, and what that simply means is that when you breathe in, that air will go to units in the lung or alveoli in the lung that also have blood flow going to it. It is absolutely no point if an area of lung is ventilated, so it's receiving fresh gas from the environment, but it has no blood to perfuse that area. There's going to be no gas exchange occurring. Also, imagine an alveoli that's full of pus or fluid. It's not going to be able to get gas in from the environment, and it would make no sense that alveoli that's full of muck is perfused with blood, because that blood's not going to get any oxygen, and it's not going to exchange carbon dioxide. So I hope that VQ matching makes sense. Now we will talk about this in greater detail in the respiratory part of our talks later in the next semester. Another important aspect is diffusion. But we know that in normal human beings without any pathology, that blood gas barrier is very thin. So that really isn't an impairment at all. Okay. The next component, remember we talked about the hemoglobin, we talked about the saturation of oxygen. Let's talk a bit about hemoglobin. What influences hemoglobin? Well, the concentration of hemoglobin is influenced, simply by a couple of things. Firstly, red cells carry hemoglobin, and red cells are produced in the bone marrow. If you have a problem with bone marrow production, you're going to reduce your hemoglobin levels. So any causes of bone marrow failure can potentially decrease your hemoglobin concentrations and potentially impair your delivery of oxygen. If you have red cell problems, for example, if you had those red cell membrane defects or enzyme defects, those red cells are going to be destroyed earlier. You're going to reduce your hemoglobin concentration. Also, the quality of the hemoglobin. So we have conditions such as thalassemias, which are genetic mutations affecting globin synthesis, and that can cause an anemia. Also, if the hemoglobin cannot associate with oxygen, if it's poison in some way, and one of the things that I didn't mention is that oxygen is not the only ligand for hemoglobin. It can carry carbon monoxide, it can carry nitrous oxide, and other substances, so it can be poison. Also, if there's bad shifts in the oxygen hemoglobin dissociation curve, the hemoglobin, although fully saturated with oxygen, may not be able to load it into the tissue, and that's the impairment with the oxygen dissociation curve. And then finally, it's the cardiac output. Now, obviously, if we're not having blood pumped, that blood that's full of oxygen is not getting into the tissues. Now, what determines cardiac output? Well, that's stroke volume and heart rate. And now we'll talk a lot more on detail with this. But suffice to say, stroke volume is how much blood the heart pumps per minute. And it makes sense that the heart needs to be loaded with blood before it pumps. So that's the preload. So imagine if a patient is hemorrhaging, so it's lost a whole bunch of blood. The blood that's coming in to the left side of the heart is only of minimal quantity. So you can't pump too much blood out. So that's low preload. Afterload is the pressure that the heart has to effectively pump against. If you have a very high afterload, you're going to reduce your stroke volume. Also, contractility. How much force can the myocardium or the heart muscle generate? If you have low contractility, you're going to impact on your stroke volume. Now, the heart rate's another thing. If you increase your heart rate, you're also going to increase your cardiac output according to this equation. That makes sense. But the problem is that there's a complex relationship with stroke volume, because if you increase the heart rate too much, what happens is you're not giving the heart time to fill with blood. So each beat that you're producing gets subsequently lower. So the stroke volume gets lower when you have extreme heart rates. And that has problems later. ANS stands for the autonomic nervous system. And again, I won't labour the point, but suffice to say, if you have a sympathetic output, that causes an increase in your heart rate, and that might also increase your cardiac output, helping you to deliver oxygen. Now, one of the other things about blood flow is that you won't get flow of anything unless you have pressure, and that pressure is generated by the heart and the vessels and in what we call blood pressure. More on that later in lectures to come. Now let's go back to our case and see if we can try and piece together briefly. So remember, we had a 42-year-old male with symptoms suggestive of pneumonia and a chest x-ray suggestive of pneumonia. Remember, this is the left lung, this is the right lung. Let me change pens to make it a bit more clearer. You can see in the left lung, it's completely opacified, essentially, with inflammation and pus. Now, a couple of things to note. Firstly, what we could imagine why this patient is breathless. Well, he's breathless because he's got essentially half his lung working, so the other half has to work much harder. You can imagine that all the oxygen in the environment really can't go this way. It has to go into this lung. So the respiratory rate goes up to try and bring as much oxygen into into the right lung as possible. He's also in a bit of trouble because his blood pressure is low, and with a low blood pressure, and this blood pressure occurs because he's septic. So and that causes the low blood pressure, and we'll explain that in greater detail in lectures to come. But because he's got low blood pressure, he doesn't have a sufficient pressure head to transport blood to his tissues. So he's not going to be delivering oxygen well to his tissues. Because of his pneumonia, he has low oxygen saturations. Remember, if you're not getting many oxygen molecules in, and you're having impaired ventilation and perfusion matching, the partial pressure of oxygen that's actually entering your capillaries is going to be low. Consequently, the oxygen saturation of your haemoglobin is going to be low. So with a low oxygen saturation, a low perfusion pressure, we can imagine that blood going into vital organs such as the brain is compromised. And this patient actually died of a cardiac arrhythmia and sudden death, because what's happened is that the heart muscles have been starved of oxygen and they failed. And I hope from a mechanistic and a pathophysiological point of view that makes sense. Anyway, thank you for listening to this set of lectures. I hope it all makes sense. Take your time to go through it. I would encourage you to read the relevant textbook chapters. Some of these concepts are incredibly difficult, and they will take time and many years of practice to mature in order to understand this in full detail. After you've finished the cardiorespiratory block, I think you'd be 90 to 95% of the way there. Again, many thanks for listening to me, and I hope you found this helpful. Do not hesitate to email me any questions. Thank you.